Hello, everybody. It's my pleasure to introduce this session. My name is Guillaume Demey. I am the president of the Lyon School of Knee Surgery. And we did on 2020 a very nice congress on monocompartmental osteoarthritis. Particularly, we had two sessions on uni from medial to lateral uni. And today, it's my pleasure to introduce my colleagues because we will present you the highlights of the Journée Lyonnaise du Genou 2020 on the topic of uni. The first speaker is Caroline Debette. She will talk about the good candidate for uni. Roger Badet will talk about limits and rare indication. Jean-Marie Fayard about results in the literature. Olivier Reynaud, the criteria of a successful UK on X-ray. I will talk about conventional medial uni and the pitfalls to avoid. Particularities of the lateral uni will be presented by Alban Pinaroli. Cécile Bataillé will talk about robotic UK, and Sébastien Lustig about post-traumatic UK. And we will have at the end a very nice discussion with two stars, David Dejour and Michel Bonnat. So again, it's my pleasure to introduce this session. It's also my pleasure to welcome you in Lyon for the next Congress. The topic is La Patella. It will be at the end of this year from 22 to 24 September. We'll talk about pain and stability, cartilage lesion management, and the prosthesis from patellofemoral arthroplasty to the TK. And the Congress will be translated in Portuguese. So I welcome you in Lyon. Please join us for this very nice session. See you soon.
Hello, dear friends from Brazil. I am Caroline Debette from Lyon School, and I will present you the ideal patient for medial uni. So who is this patient? First, the patient must present a good indication, osteoarthritis or osteonecrosis localized to the medial compartment. Then, ideally, there must not exist various criteria which risk to lead to complications and failure. Concerning the age of the patient, neither too young, neither too old. Too old is not really a contraindication, but with old patients, you have to be careful with bone quality, which can be poor. So be careful during surgery to cover the tibial surface to avoid secondary infection. Not too young and for several reasons. First, at this stage, maybe the tibial osteotomy has to be discussed. Then the functional requirements of the patient, which may not be compatible with the uni. And finally, young patients are exposed to long-term wear with the need to prosthesis revision. Concerning weight or BMI, not too heavy. Too much stress will lead to pain, wear, loosening. Concerning the knee himself, the varus must not be too important and has to be reducible, once again due to the significant stresses that the implant will undergo. The cartilage lesions have to be localized to the medial compartment. The knee has to be stable, particularly with the ACL. Not too stiff, since the uni does not allow to perform release. So by mixing all these criteria, I arrived at this ideal patient. Cousin and Scott in 1989 had been very precise about the medial uni indication criteria. You can see them here. But if these criteria are strictly retained, only 5% of patients will be able to benefit a uni. Uni failures are mainly related to two causes. One, technical mistakes, and two, indication mistakes. So if we want to reduce mistakes, we must increase the experience of the surgeon. And it's not with 5% of uni that it's going to be done. Since 1989, the indications have been slightly expanded, but the limit remains unclear. So what is different since 1989? We could see the UIS, the Unicompartmental Indication Score, published in 2019 by Antoniadis, which is therefore a help to patient selection in which you find all the parameters mentioned above with a quotation. More you have points, more you can have a good results with the uni. Above 25 points, it's very good. Below 20, it's not good. And maybe we need to discuss another treatment. Between 20 and 25, it remains unclear and the indication will therefore be left to your intuition. Finally, the perfect situation is the one that presents the ideal patient and the ideal surgeon face to face. The ideal patient has a good indication and no contraindications. The ideal surgeon combines technical skills, experience, and ability to orient himself in his therapeutic choices. We can all embody this surgeon, and there is no doubt that after this Journée Lyonnaise du Genou, we will all be closer to him than we have ever been. Thank you very much.
Dear friend, I'm very happy to be with you today and to participate in your Congress through the Lyon Square. I miss Brazil and my Brazilian friends, and I will be very happy to see you in Lyon or to come in Brazil and see you soon. So my topic is uni-compartmental knee arthroplasty, causes of failure and traps. It is difficult to talk about UKA in our group without mentioning Pierre Chamba and Gérard Deschamps. And I advise you to read the editorial of Maîtrise Orthopedic, which was specially edited for our days dedicated to the UKA. The UKA represents 15 to 20% of the knee prosthetic activity, with an excellent survival curve of nearly 86% at 10 years. Two main causes of failure: poor indication, technical implantation abnormality. The UKA is subject to a demanding environment and has a fragile balance. Be careful when the frontal deformation is important, and the UKA should be avoided if the global deformation is greater than 10 degrees. The risk in case of important residual deformation is that the forces transmitted to the prosthesis are excessive and lead to pain and losing of the UKA. In the UKA, the conventional deformity should not be corrected, and the objective is not to have 118 degrees alignment. The correction must be individual, and the residual deformity value should be known on planet. Osteoarthritis can be significant, but frontal tibiofemoral subluxation contraindicate UKA. The deformation must be reducible because the risk of the fixed or partially reducible deformity exposed to residual medial lateral subluxation. Great care must be taken with an opposing tibial femoral compartment, which may deteriorate either as part of a V-correction, as you see here, or as you can see here, as part of globalization of arthritis, generating pain in the no-podis compartment, treated in this patient by a UKA with an excellent result. Many authors minimize the role of patellofemoral joints, but they are very related to residual patellofemoral pain. Therefore, the patellofemoral joints must be carefully considered in pre-operatively. Failure of indication of ligamentary origin are mainly related to ACL tear, which is classically a known indication for UKA. In case of ACR tear, the anterior subluxation of the tibia can lead to a rocking chair effect on the posterior part of the tibial plateau, source of early failure by dislocation. Some authors suggest when the ACR is tear, it should be reconstructed at the same time as the UKA. Some factor of failure may be related to the patient. This later as Caroline explained in the previous presentation to define the ideal patient. Weight and level of activity, which is undercorrelated to age, can lead to pain due to overall of the prosthetic compartment. There is no age limit of the UKA, but it is recommended for older patients. Concerning weight, there is no consensus in the literature, but it is advised to avoid UKA in obese patients whose BMI is higher than 55. The cause of failure can be related to technical error. Here, a tibial implant, which is oversizing. In this case, a painful with meniscus remaining, which was treated by arthroscopic removal of the meniscus. Here, pain related to the presence of a little cement at the posterior part of the joint. There are risks of failure associated with the previous procedure. Classically, it is not advisable to perform a UKA after high tibial osteotomy. Even it, as in this case, it can sometimes make the surgery less invasive with good results. Do not revise the failed UKA with a UKA, which reduces 70% failure rates. In this case, it's recommended to do revision with total knee arthroplasty. Finally, and this underlines the importance of the information given to the patient. There are subjective failure when the result is not what the patient has hoped for. So in conclusion, be demanding of your indication and your technique to success in the UKA. So, molto obrigado.
Hello everybody, thanks to the organizing committee to give me the opportunity to present the results of the different types of medial unis. In medial unis, there are different types of designs and concepts which are quite different in terms of philosophy. I will expose you the clinical and the radiological results of those different designs. First, we will compare full poly versus metal-backed uni in terms of clinical and radiological results, survival and complication and revision rate. Full poly has the advantages, first, to be cost effective compared to metal-backed, second, to preserve the bone stock because a thinner implant is required for the same polyethylene thickness. But full poly is associated with an increased risk of excessive tibial strains and tibial loosening. Finally, metal-backed unis are associated with a specific risk of backside wear and polyethylene breakage. Considering this recent meta-analysis, full polyethylene and metal-backed implant do have the same mid to long-term results with more than 84% survivorship. This meta-analysis included more than 500 knees from each group. No difference was noticed in terms of functional score. The authors reported a trend to lower risk for aseptic revision with metal-backed. They concluded that both full poly and metal-backed implants provide excellent clinical and functional results. Survivorship may be potentially improved with metal-backed implant. Now, let's talk about cemented and cementless implant. Cemented fixation is the gold standard, but cementation mistakes may lead to impingement with the implants or the soft tissues or accelerated wear. In contrary, cementless implants are associated with faster surgical time, reduced risk of tibial radiolucent line. Special attention should be paid to primary fixation of the implant to avoid migration. Both types of implants have similar mid to long-term results with 80 to 100 survivorship rate. Mid to long-term revision rate is low and similar in both groups, 2 to 14% in cemented implants, 0 to 17% in cementless implant. What about functional scores? No difference is reported between the two groups. Concerning radiological outcome, radiolucent lines seem to be more frequent in cemented tibial implants without any clinical implication. When considering short-term survivorship, excellent outcomes are reported without any revision in both groups. Similar constatation is suggested by mid-term randomized control trial. What about fixed versus mobile bearing? Fixed bearing has the advantages to be aware of bearing dislocation, but are exposed to an increased risk of polyethylene wear and tibial loosening. In contrary, mobile bearing, by increasing contact area, decrease contact stress and the risk of polyethylene wear, but those implants require perfect ligament balancing to avoid bearing dislocation. In his meta-analysis, Kao reported similar revision rate at short and mid-term follow-up in both groups. This rate was 11% in the fixed bearing group and 13% in the mobile bearing group. The authors didn't find any significant difference in terms of functional outcomes. This study analyzed almost 2,000 knees and concluded that mobile bearing had significantly more bearing dislocation. But those implants had also significantly less bearing wear. Fixed bearing seems to be associated with a lower risk of revision, but this was not significant. Finally, fixed and mobile bearings both provide excellent outcomes, even if mobile bearing are associated with an increased risk of dislocation and fixed bearing with an increased risk of polyethylene wear. Now let's talk about bone resection and resurfacing unis versus inlay unis. Unis has the advantage to preserve the bone stock, but are trickier to restore the joint line. Anyway, no difference is reported concerning the survivorship, with excellent mid to long-term outcome in both groups. As a conclusion, all different types of uni designs and concept provide excellent outcome, and no difference is reported between different types of implant. But each type of implant has its own specificities, and we finally recommend to use the implant you are familiar to. Thank you for your attention.
Hello, everyone. It's a pleasure for me to be with you today and to talk about radiological criteria for a successful medial uni. To analyze the good position of your uni, you will need three different X-rays: the AP view, the lateral view, and finally the long leg film. On the AP view, we will check the varus of the tibial implant, its size, the femoral component inclination, its mediolateral position, and finally the height of the joint line. The tibial varus will influence the kinematics of the medial compartment and the stress experienced at the bone prosthesis interface. It is recommended to respect the tibial epiphyseal axis without exceeding 5 degrees of residual varus. Beyond this 5 degrees, there could be a significant risk of loosening. About tibial size, the purpose is to find a compromise between sufficient bone coverage, which means covering the bone where it is strong enough, therefore at the periphery of the bone cut, as described in many biomechanical studies, and thus avoid an early sinking in case of undersizing of the tibial implant. But it's also important not to overflow the cortex, which could lead to pain and stiffness. Concerning the coronal inclination of the femur, the rounded shape of the femoral component gives its tolerance in the positioning in various values. This tolerance depends, in fact, on the specific data of each implant. The Uni Oxford, for example, is given for a tolerance of 10 degrees around the mechanical femoral axis. The femur tibia contact point moving significantly influences the wear of the polyethylene. This point of contact can be modified by the medial lateral position of the femoral component. A good compromise could be to center the femoral component on the medial condyle, but it is probably also necessary to take care about the position of the tibial component and center the femur in relation to this one in order to better distribute the stresses on the polyethylene. In the total knee arthroplasty, the modification of the joint line height can lead to stiffness, inflection, and pain, but its modification in the uni has much more complex consequences due to the asymmetry of the medial and lateral compartment that results. The purpose, the purpose is therefore to restore it as much as possible. It's generally accepted that lowering the joint line leads to a greater bone resection at the tibia in a more fragile spongious area, and an undersizing of the tibial component responsible for a displacement of the femur tibia contact point towards the periphery of the tibia, adversely modifying the constraints. From a functional point of view, this translates into pain, possible stiffness, even early loosening due to the excess of stress on a more fragile bone. Let's talk about the lateral view now, on which we will analyze the tibial slope on the one hand and the femoral component position on the other hand. Necessary for a good kinematics of the knee inflection, the pre-op tibial slope should be reproduced as much as possible, avoiding exceeding 7 degrees of residual slope, which could lead to overload the ACL. For the femoral component, we will essentially look for the absence of any overhang, especially anterior, responsible for an impingement with the patella inflection. In practice, if the overhang does not exceed 2 or 3 millimeters, there is no superstructure in relation to the trochlear cartilage. Finally, the last shot is the long leg film, which will allow analysis of the mechanical femorotibial axis. The trend is for a slight hypocorrection from 3 to 5 degrees for Bruni in 2009 in the KSSTA, or of 2 or more or less 2 degrees for Cécile Bataillé in the same journal. Nevertheless, taken independently, these values don't mean much, and it will above all be a question of knowing the pre-op deformity and of partially correcting it. Excessive undercorrection could lead to residual pain, excessive stress on the implant with wear of the polyethylene, or even early loosening. Conversely, hypercorrection would overstress the lateral compartment and risk a rapid degenerative evolution of this one. In conclusion, on the AP view, we will check the good bone coverage of the implants, the preservation of a slight residual varus, the correct centering of the femur in relation to the tibia, and the absence of any modification of the joint line height. On the lateral view, the reproduction of the tibial slope and the absence of any anterior overhang of the femur are checked. And finally, on the long leg film, hypocorrection of the femorotibial varus seems to be the rule.
Hello, everybody. My name is Guillaume Demer. We'll talk about medial fixed bearing UK and conventional surgery. The fixed bearing UK is a round and flat articulation. It's unconstrained design with a curved femoral component on a flat tibial plateau. The soft tissue will dictate motion of the knee and the poly will deform by creep. And you can accept limited varus or valgus tilt of the femoral component without age loading. The amount is depending on the prosthesis that you use, so you have to check on the manufacturer details to know that. And I will show my top 10 technical considerations for this conventional surgery. The first one is to avoid any release, and you have to keep the deep MCL completely intact. The second one is to use landmarks. They are very important during the surgery. The center of the posterior medial condyle is a good landmark, the center of the medial tibial plateau. And in full extension, you have to mark the center of the anterior medial condyle and the contact point in full extension. So it will give you a good landmark to have a good positioning of the prosthesis. Then you have to restore the tibial anatomy. And the first one is the tibial varus. You need the long leg films to do the measurement of the tibial varus, and you have to reproduce it at the time of the surgery using the guide to be really close to the anatomy of the patient. In the sagittal plane, it's the same. You have to restore the slope. So you need X-ray to do the measurement of the slope precisely, and you have to restore the slope. I use a metallic pin guide to reproduce the slope at the time of the surgery, and it will help me to have a good positioning of the guide. On the horizontal plane, the thickness of the cut should be done precisely, and I use the medial osteophyte as a good landmark. The cut is usually just under this medial osteophyte, and the medial meniscus wall is also a very good landmark to check the joint 8 positioning. Then the horizontal cut orientation, you can follow the center of the femoral head to have a good orientation of this sagittal cut. So the tibial cut is very important, probably the most important part of the surgery. You have to avoid any risk of mechanical failure. And you have to avoid any residual mechanical varus. It should be less than 5 degrees. Any change in tibial component obliquity, it should be less than 3 degrees. The posterior tibial slope should be less than 7 degrees. And the change in slope less than 2 degrees. And the joint space position is also important. You have to avoid any change over 2 millimeters, and the divergence between the tibial and femoral components should be less than 6 degrees on the literature. Then the stability of the tibial triangle is very mandatory. And at the time of the surgery, you have to test it in flexion and during the range of motion from flexion to extension, and you have to test the laxity. If it's too tight, you have to think about recut the tibia. Usually it's 2 millimeter recut. If you have a lift off of the spacer, you have to think about increasing slope and to resect the posterior medial meniscus. If you have a residual meniscus, it could give you some lift off. Then you have to align the femoral component in extension. You have to be aware that if you have any flexum of the femoral component, it will have impact on the gap in flexion and extension. So avoid any flexum of this component. Then you have to align the femoral component in flexion, and remember that we talk about landmarks in flexion of the femoral condyle. So it's very important now to have a good positioning of this component, and you have to be at 90 degrees from the medial plateau. Then you have to avoid any overhang of the prosthesis. It's like TK principles. Then the final control is very important before implantation. This example, I use a 9mm tibial trowel. It was too tight. It was impossible to have any laxity. And with the 8mm tibial trowel, this is very perfectly obtained. So we went for 8mm tibial trowel at the end of the surgery. So this is a selective surgery, and the tibial cut should be done right. This is probably the most important part of the surgery. You need a slight laxity, no overhang, and you will have a good implant survival if you have a good positioning. So it's why we will see that new technologies may help a lot for this surgery. Thank you very much.
Hello. First of all, I would like to thank you for the invitation, and I'm glad to be with you by the voice. So let's talk about the particularities of lateral unicompartmental arthroplasty. First of all, lateral osteoarthritis has particularities as constitutional femoral valgus. It mostly consists of a distal femoral hypoplasia without posterior dysplasia. So, when osteoarthritis occurs, there is an intra-articular bony deformation with femoral distal wear, a lateral osteophyte, and a tibial wear with a central cup. Sometimes, a lateral curvature of the femur adds an extra-articular deformation. Lateral femorotibial compartment has also anatomical particularities, with a double curvature of the lateral femoral condyle and an important anteroposterior mobility of the lateral tibial plateau and meniscus. These concerns explain particular design of the lateral UKA, necessitating a fixed tibial component, even for resurfacing Oxford technique, and sometimes a different design of femoral compartment with double curvature. Let's see now the indications of lateral UKA. The best and most common indication are for primitive lateral osteoarthritis with isolated wear, reducible deformation, and no fixed retractions, with a distal femoral hypoplasia with intra-articular deformation. The equivalent good indication is for secondary arthritis after lateral meniscectomy. Please note that associated moderate lateral patellofemoral arthritis is not a contraindication and can be treated at the same time by lateral sagittal patellectomy. Other indications also exist, for example for malunion after lateral plateau fracture. It is technically difficult and sometimes necessitating the use of a frontal screw under the tibial component to ensure stability in bad quality bone. Other indications are rare, as B-uni at the same time or delayed, uni after HTO, or associated with AC. Some technical features are interesting to know for surgical technique. Installation is the same as you use in your practice. A lateral Keblish approach is recommended. Positioning the prosthetic components is tricky, and the principal risk is to have a conflict between the spine and the femoral component, and/or a bad femorotibial tracking. In order to avoid this, put the femoral component as lateral as possible, even on the lateral osteophyte. Ensure also you have a proper exposure to make a good tibial cut. For that, beware of the screw-home mechanism and apply a forced internal rotation of the foot, as you can see on this picture. Surgical tools are interesting to help us, as for total knee arthroplasty. PSI can be useful, especially for guiding the tibial cut. CAS is precise for targeting the best frontal alignment. Nowadays, robot is probably the best tool to achieve good gap balancing, well-aligned prosthetic tracking during all the range of motion, and ideal frontal alignment of the knee. After the surgery is done and in the good indication, results of lateral uni are very good, clinically and in terms of implant survivorship, with 90% survival at 10 years and 75% survival at 20 years. I thank you very much, and I hope to see you in Lyon in a few days.
Hello everyone, we will talk about robotic unicompartmental knee arthroplasty. Unicompartmental knee arthroplasty is challenging due to a higher risk of revision with a uni compared to a TK, and this risk is due to a malpositioning and malalignment risk. Indeed, we need a perfect surgery to have a good functional outcomes and a good survivorship. For that, you can use a robotic system, and for the uni, we have two main robotic systems, an imageless robotic system with the Navio of Smith & Nephew. This robotic system is based on bone morphing during the surgery, and after your bone morphing, you can plan the surgery on the screening. After the plan, you can remove the bone with a burr, and this bone resection is according to your plan. Or you can use an image-based robotic system with the Mako of Stryker. So for that, you perform a CT scan before the surgery, and before the surgery also, you can plan your unicompartmental knee arthroplasty on the CT scan. After, during the surgery, you can remove the bone with a burr or with a saw according to your plan. This robotic system improves the accuracy of the surgery. We compared two groups, one with a mechanical technique and one with a robotic system, and we found an improvement of the accuracy of the bone resection, an improvement also of the joint line restitution, avoiding an excessive tibial cut. We compare also the rate of outliers with a robotic system or with a mechanical technique, and we found less outliers with the robotic system for the lateral uni and for the medial uni. We found also an improvement of the implant positioning and an improvement of the frontal alignment with the robotic system compared to a mechanical system. Thanks to the improvement of the implant positioning and the knee alignment with the robotic system, we found also an improvement of the revision rate with the robotic system, and it's mainly for the lateral uni. We have compared also the sizing of the uni with 3 techniques, mechanical technique, image-free robotic system, or an image-based robotic system. So we found improvement of the sizing of the uni with a robotic system, and it's mainly for the image-based robotic system. So with a robot, with a without CT scan, you can decrease the rate of posterior femoral undersizing. And with the image-based robotic system, you can improve the femoral posterior offset, and you can decrease the rate of posterior tibial undersizing. The robotic system is also a safe procedure. We have assessed the risk of complications due to the robotic system in our patients, and we found no specific complication of the robots. For the functional outcomes, we compare also the functional outcomes between a robotic system and a mechanical technique, and we found a good functional outcomes after uni in both groups with no significant difference between both groups. For the return to sport, we found also a similar outcomes with a robotic system or with a conventional technique. We compare also the gait analysis with a conventional technique and with a robotic system during a randomized study. And we found no significant difference for the gait analysis between robotic unicompartmental knee arthroplasty and the mechanical uni. With the robotic system, you can also have a more challenging indication. So you can do a uni associated with ACL reconstruction, or associated with a patellofemoral prosthesis with a good functional outcomes. Or we can discuss also medial and lateral unicompartmental knee arthroplasty associated with a patellofemoral prosthesis. So in conclusion, uni is a challenging surgery, but with a robotic system, you can improve the implant positioning, the knee alignment, and you can decrease the risk of revision with a good outcomes and without specific complication of the robotic system. So we have strong arguments to perform uni in safe conditions with a robotic system. And in the future, the artificial intelligence will probably improve also the functional outcomes. Thank you.
Dear friends from Brazil, it's a pleasure to be remotely with you to talk about lateral uni for post-traumatic osteoarthritis. I will acknowledge my co-author, Cécile Bataillé and Elvire Servien, and also all the team from the Lyon Knee School of Surgery. Post-traumatic osteoarthritis is a very challenging situation. Most of the time, it's about the lateral tibial plateau. It's for young patients with questioning, bone quality, and they expect really high functional outcomes. So it's a tricky situation. A good example to show you why this is tricky, you can see this gentleman, it is a patient from Philippe Neret. He was 31 years old, 105 kilograms when he came to our clinics. You can see the MRI, the CT scan, and also the stress X-ray showing a huge gap here. And this is where, this is a good indication. At that time, there was nothing really published in the literature about this. And really want to acknowledge Philippe Neret to be a pioneer in this field. And this is how we treated this patient. And this is the 10 years, outcome with the lateral uni, and still a pretty big guy, and considering the outcome at 10 years, I think it was very interesting. So we published the results of this with the combined work done with the team in Marseille, with Professor Parrott and Arjanson, and showing at that time it was, a nice strategy to deal with this situation. So we kept, operating on this patient with this strategy of lateral uni. This is an example with a severe bone loss, malunion, intra-articular, previous, osteocentesis, and you can see here the post-op X-ray, which seems to be a simple solution for a challenging situation. This is showing you why it's tricky. Most of the time you have a very severe valgus well above the threshold we usually consider when we're doing a lateral, a uni. But in this case, if you add the pre-op CT, you can see the bone loss and also the intra-articular malunion. I'm not sure we can deal with this with an intra-articular osteotomy or with a conservative surgery. Again, Philippe Neret showed us how to deal nicely with this situation. You just restore the joint line with the partial knee replacement, and then you add 1 or 2 screws to improve the tibial fixation. This is the typical post-op X-ray from the patient I showed you with the 2 screws to improve the fixation on the tibia side. I would like to acknowledge Axel Schmidt is one of the members of the Lyon Knee School, and he did an amazing work to try to assess the outcome at long term of this patient. This is 18 lateral post-traumatic uni with minimum 10 years follow-up. Mean follow-up was 11.4 years. And we had a control group of 36 lateral uni, and we compared the outcome of these 2 groups. What was interesting, young patients at the time of surgery, and the delay between the surgery and the trauma was pretty short, showing that this situation is absolutely not well tolerated for these patients. Most of them had a previous osteocentesis which failed. This is a typical situation, almost more than 10 degrees of valgus, good reducibility, the hardware is still in position, and this is the solution with the lateral uni and the additional 2 screws. This is an even more tricky situation. This young patient, he had the hardware still in place, a septic history, very severe malunion intra-articular. We had to consider removing the hardware. You can see here 10 degrees valgus. The intra-articular situation is very challenging. We considered a pre-op CT to get a proof that the bone was healed, which was nicely showed here. And then we considered the lateral uni, adding 2 screws, as I showed you, with a very nice outcome. This is another situation where the bone loss is even more significant. And in this situation, if the 2 screws are not sufficient, we add a plate just like this to improve the fixation on the tibia side, with also an interesting outcome. You can see here the results of the study. We did clinical outcome with minimum 10 years. You can see, depending if it's post-traumatic or standard situation, similar improvement, similar outcomes. This is an example of a patient of mine I operated on 13 years ago with a lateral uni, adding 1 screw to improve the fixation. This is the outcome at 6 months. And you can see here, this gentleman at 13 years follow-up, you can see the X-rays situation, the lateral uni is still in place, no specific wear of the polyethylene, good alignment. And you can see here the functional outcome for this gentleman. He's got a normal life. He had a normal life for 13 years. He's extremely happy with the results. You see, still doing motorcycle, as you can see here, very good range of motion, no pain, and probably going to stay like this for another, 10 or 15 years. So definitely a nice strategy to consider for this young and active patient. Look at this curve. 10 years follow-up, 95% of survivorship, 20 years follow-up, 64.8. Still very interesting when you consider the situation from the beginning. So take-home message, lateral uni for post-traumatic OA is a challenging surgery, excellent functional outcome, and similar survivorship to lateral uni for post-traumatic OA. So something to consider. I would like to thank you for your attention. I know you're going to have a nice discussion with David and Michelle, and I'm looking forward to seeing you all in person in Lyon or in Brazil very soon.